You have an opportunity to try to find it. We'll also be using the chat for you to add questions if you don't like coming on screen and asking them directly once we get to the Q&A session. So if things come to you, please feel free to drop them in the chat. Give it one more minute and hopefully we'll get more people on joining us before slowly adding in. For those of you arriving, welcome to our ReCAST Town Hall. Let's talk about COVID-19 vaccine. Okay, let's go ahead and get started. Hi, I'm Vetta Sanders Thompson. I'm going to be your moderator this evening, and I want to welcome everyone to this town hall. Our meeting is now streaming live on Facebook, so ask your friends and family to join us, have their questions and concerns addressed and answered. We have a wonderful panel here to speak with you tonight. I am so proud to have these women, these individuals join us this afternoon. And so the first thing I'm going to do is call on Paula Sutherland, who will talk to you about ReCAST and introduce her staff and present a description of this program that has been a major part of this region and the Promise Zone for the last 4, now going on 5 years. So Paula.
Thank you, Vetta. Dr. Thompson. Good evening. My name is Paula Sutherland, as she said, and I'm the program manager for St. Louis ReCAST. On behalf of our team, everyone here, I want to thank you all and just welcome you to, again, let's talk about COVID-19, vaccinations. So I'd like to say, since there is no I in team, I also want to introduce the rest of the ReCAST staff. And so I was trying to look through the pictures to see, but Damon Broadus is new with us. He is now the Director of Health Promotions at St. Louis County. And then Gina Traver, who is actually our Community Health Manager and works directly with us on ReCAST. And then finally, I got to bring up, least but not last, Miss Ebony Hooper. She is the one that's instrumental in all of our community engagement, as well as our participatory budgeting efforts. If you're familiar with ReCAST, she's going to tell you a little bit more about that because she leads that effort, but I'll turn it over to her. Thank you.
Ebony, you're on mute.
Yes, of course. Hello, everyone. My name is Ebony Hooper. I am the Community Engagement Coordinator for the St. Louis ReCAST grant. And thank you for joining us this evening. So St. Louis ReCAST is all about participatory budgeting. It is a $4.7 million grant that was awarded to St. Louis County in 2016. So pop quiz, we are in our 5th year. And within this year, we really wanted to talk about with community and engage community on a series of topics. Last year, when the pandemic began, we had a coping with COVID event, and we saw it only that we followed up and continued this conversation to talk about where we are today with the vaccination. And so for being here with us, participatory budgeting is really the crux of our project. Residents have a say in what projects are funded in the community in the St. Louis Promise Zone, which is parts of the city and parts of North County. And those same residents also had a say in the events that we should be doing within our 5th and final year, one of which was related to the COVID-19 vaccination. So with no further ado, I will pass it to our wonderful moderator, Dr. Thompson.
Thank you, Ebony, and thanks, Paula. So before we get into the program, and we have another group that we work with as a part of the ReCAST family, and that's the Patient Research Advisory Board. Many of you are aware of the Patient Research Advisory Board because of the work that they do in other areas. And so I'm going to ask Jackie Wilkins to come on and just describe the Patient Research Advisory Board, what they do, and ways that they've worked with ReCAST, and ways that you can get involved with them out in the community. So Jackie.
Hi, and thanks for all of those that are joining in this wonderful endeavor here. I basically am the co-chair for the Patient Research Advisory Board, and I'm standing in for Dr. Vanessa Lloyd, who had an urgent medical need to attend to today. But she is one of the core members of our Patient Research Advisory Board that participate with ReCAST, along with, we actually have 4 representatives. That's Dr. Vanessa Lloyd, Carlette Lewis-Roan, and Tanya Webb Carr, and then we have James Wallace. They have been participating with the ReCAST group and supporting all the efforts and programs and events representing the Patient Research Advisory Board. So we're glad for that. And they probably have more information. I haven't attended any. I do support the events that our team members do as well. But what the Patient Research Advisory Board, what we exist for, is to bridge the gap between the communities, whether it's the research area with projects and ideas and that they would like to have, or on the community advocacy side, to help communities be aware of things that pertain to their health needs, to address the health disparities that they have concerns with. So we have worked with different groups and investigators. We have programs and a tool that we use where researchers can actually submit their projects or ideas for us to review from a community standpoint to see what we can contribute to make sure that they have a successful project, looking at it from the eyes of the community. As well as then from the community side, we also look at things and want to engage the community so that they can be a part of issues and concerns with health disparities that they are concerned with. So we work both sides to collaborate and bring the groups together. And we've been, the Patient Research Board was established back in 2013, and we are actually all members of the Community Research Fellows training that was offered by WashU. And we have different individuals that participated at different sessions that was held for that. But we're here for the community, we're here for the researchers, and we love to be involved. We're primarily focusing on violence prevention, which was this past year, our efforts are kind of focused in that area. But we are open to other ideas and projects to see what we can do to support the endeavors that individuals may have. So we have at least, it's 15 to 16 Patient Research Advisory Board members, and we have monthly meetings. We have an email address, so if anybody has any projects or ideas that you would like to submit, and you can schedule a meeting, we can put that, I'll put the email address up in the chat, so that way if you would like to reach out to us directly to schedule a time to discuss your issues, your concerns, or your projects, we are available, and we love to be involved in community efforts.
Thank you, Jackie. And now we get to the part that I know is what everyone wants to hear. And that's from our esteemed presenters and panelists today. First and foremost, I won't say foremost because I don't want to slight anyone else, but you can tell I have a slight bias. We have Dr. LJ Punch. Who, after a successful undergraduate degree at Yale, Dr. Punch began her medical training at the University of Connecticut School of Medicine. After medical school, Dr. Punch completed a residency in general surgery at the University of Maryland Medical Center in Baltimore, then a surgical critical care fellowship at the R. Adams Cowley Shock Trauma Center in Maryland. Dr. Punch is a leader in public health in St. Louis. You probably don't need to hear an introduction of Dr. Punch from me. People probably know of her work, but Dr. Punch has spent a great deal of time after spending years as a trauma surgeon in Baltimore and St. Louis, and some time as professor of medicine at the Institute for Public Health. Dr. Punch is now focused on the T. And this is an effort that she started. It's health education that they started. It's health education and a resource center in the East Loop. It was founded in January of 2019. The T has been working with a volunteer group of health professionals to bring resources and training into the community to reduce the impact of violence. The T provides trauma first aid training. I participated in her Stop the Bleed program. I still have my kit. I have encouraged other people to get that training. In addition to the kits with the materials like tourniquets, they do other things. The T takes on issues such as homelessness, opioid addiction, and then of course, when COVID hit, as you would expect, Dr. Punch was there. We also have Dr. Jane O'Halloran, who joined the Department of Medicine in the Division of Infectious Diseases as an assistant professor in July of 2019. We really appreciate her taking time to do this session. She's originally from Ireland. Dr. O'Halloran studied medicine at the National University of Ireland in Galway. She completed specialist registrar training in infectious diseases and internal medicine in Ireland, where she also did her PhD thesis. Her PhD work was related to mechanisms that contribute to cardiovascular disease and HIV infection, which is one of her areas of specialty. She subsequently went on to do a fellowship in infectious diseases here at Washington University in St. Louis. Her research is in comorbidities associated with HIV infection. She is particularly interested in those comorbidities that I mentioned, which include cardiovascular diseases, lipid disorders, and neurocognitive functioning. But Dr. O'Halloran has also worked with the infectious disease team at WashU that was involved in the COVID-19 vaccine trials. And last but not least, we have our great friend and television star, Dr. Matifazda Hlathswayo Davis, who is an infectious disease physician at Washington University in St. Louis. She was recently appointed to the St. Louis City Board of Health. She's also co-chair of the Fast Track Cities St. Louis, which is an initiative with the goal of reaching 0 new HIV infections and AIDS-related deaths in the region by 2030. She also sees patients at the VA hospital. She received her BA magna cum laude from Drury University. She received her medical training at the Cleveland Clinic Lerner College of Medicine at Case Western Reserve University, and completed her internal medicine residency at the University Hospital's Case Medical Center. Dr. Madi completed an infectious disease fellowship at Washington University School of Medicine, a 1-year HIV fellowship here, and a 2-year dedicated STD fellowship as well. Her interests include HIV, hepatitis B and C, and she has worked on several of the COVID-19 studies that were conducted to better understand the prevalence and the course and needs of members of the community in St. Louis County. So with that, I'm going to turn it over to our panelists. We'll start with Dr. LJ Punch.
Hey, so excited to be here. Am I just freestyling here, or do you want me to make a particular comment?
What I really would like for you to do is talk about what you're seeing related to COVID-19 in the community and what you think the community members need to know and what you advise that they consider at this point in the
So
COVID-19 pandemic.
I have been completely spoiled by working with an incredible group of leaders in the region who have been active in supporting both public health and social structures. That is the Prepare STL campaign. And as a physician, to be able to work on a day-to-day basis for a year with people who are standing in the gap, trying to make sure that community members, people of color, and specifically Black folks in St. Louis are served has been quite possibly, like, you couldn't design like a fellowship better than this, of what it's been to be in that gap. And along the way, I've really had the opportunity to see what it looks like when community members grapple and hold into accountability medical systems and healthcare systems around the issue of historical, racial, medical trauma. Because when COVID hit, the medical community needed individuals and community members to jump, because this time the fire was real. But not having those relationships, not having that trusted dialogue and communication, our healthcare systems were really at a lack and desperately needed trusted messengers along the way to communicate that it really is time to jump. So being part of that work and being integrated into that, and now being in what we're calling sort of COVID 2.0, the new era, I've really been thoughtful about how we can continue that trusted messaging when now what's on the table is the question of the vaccine, because that represents an even greater example of how racial medical trauma shows up for folks. And so what I'm hearing from folks right now is some real interest and some real anxiety, some real concerns, and some real trauma around what it's been like to live with COVID for a year and what it could mean as we go into the summer and another year. And what the message I've been bringing and the words that I've been bringing have really been to find ways to speak to the people's individual and communal power to make a choice about what the next year looks for them, including the ways in which they will enhance and protect and support their own immune system, recognizing that COVID, although the numbers look better, is still here to stay. So what I'm hearing is a diverse set of concerns. Very multiple different opinions, multiple different experiences, multiple different perspectives. And what I've been striving to do, right, is to give power to those diverse opinions and thoughts by helping people have what they need so they can make an informed choice. And I never thought that a pandemic would reveal this kind of opportunity to be working so deeply in community. And I'm so grateful for those leaders from Prepare STL that have allowed me to do that as a physician in this last year.
I'm going to ask you just one or two questions that we think, based on the conversations that have occurred, will be of interest to the audience. And one is, some people are asking why they should take the vaccine if they are not high risk. And what would you say people should think about?
Do you want me to answer that, or do you want the skilled Dr. Madi to answer that?
I've got a set of questions for you.
Okay, well, let me just frame it. I'll frame it and say, again, it's not what I think. It's about me helping you make a choice and your physician helping you make a choice. And so I like the word risk here, because the word risk is really how we make decisions whenever we're facing, right, a medical choice where there isn't necessarily a clear path. You have to think about risks and benefits. And the risks and benefits that you can think about are for you, are for your family and loved ones, and for the community you lived in. And the way those risks and benefits add up at those three levels, might be different. And so what I would say to someone if they said, I'm not high risk, why should I take the vaccine? I would be like, whoa, let's slow down. Let's think about the world that we live in. COVID is here. And unfortunately, variants are making it so the battle has not stopped. What are the things that compromise risk? It's not just your own health, it's the exposures you have. And then what risks do those risks convey to the people in your family that you love? And what role and responsibility do you have the community overall that you're part of? And so suddenly the conversation is not simply this binary, like do it, don't do it, right? But it's more like, how do I show up for my body and my well-being, but also for those around me that I love? And how do I, measure both the risks and benefits? Because while somebody might not have a great deal of healthcare risks, the benefit of
Am I frozen or is Dr. Madi frozen? I mean, or is Dr. Punch frozen? Dr.
Dr.
Punch,
Punch.
Dr. Punch, I think you're frozen.
me as a physician saying, you should just do this. I'm not into that. I'm into helping support it. Oh no. Oh,
Okay.
I guess I just got unstable for a second, but it looks like I'm not unstable anymore.
Okay. Well, we can hear you now.
Okay, sorry.
Dr.
So,
Punch, you were just about to walk us through risk and benefit, the benefit side of it.
so the benefit, right, is not just about the whether or not you have a healthcare risk, but it's about thinking about your exposures, the exposures that you might bring to the family that you live with, and the way that you can show up in your community to both just navigate day-to-day life and to serve. And so, it's not just about the risks of getting really severe COVID. It's about the risk that you represent, to everyone around you. And I think that changes the conversation. Now, for some, right, they're like, I don't need to think about that. And we really haven't embraced as a culture in this country, right, that sort of larger set of responsibility to the people around us. Now, that's a philosophical thing, and I know where I sit on that. I'm not going to push that on anybody. But I think the pandemic has taught us a little bit about the way our choices cannot be separated from the choices of the people around us. So again, wouldn't just have a conversation about your own health and your body, but really try to expand your idea of risk and benefit so that it's more nuanced.
And thank you for that. And then one last one, and then we're going to move to Dr. O'Halloran. So just to put you on notice, Dr. O'Halloran, so you can be prepped. But one last one. One thing that comes up is people want to know, okay, if I get vaccinated, then what will I be able to do? So can you talk about how you have been thinking about that and how you've been presenting that in the community?
So I have been encouraging everyone, regardless of their choice with the vaccine, to think about what it means to have a healthy immune system. And I have been talking about sleeping and eating and nutrition, especially key vitamins like C and zinc, getting sun, getting sleep, getting ways to decrease your cortisol levels and handle stress, and ways to keep a physical barrier from the virus, masks, face, hygiene. So, those things aren't stopping. That's really important because for me, the vaccine is simply a continuum of a plan to support the health of your immune system. And everyone can make the choice to support the health of their immune system. If someone makes the choice to augment, to add to their immune system's ability to fight COVID, they have to recognize that that is not an absolute. One, because COVID's really smart, and two, because our immune systems are tricky. And so I'm also really encouraging people that this is one piece of the puzzle that they can do. So quite honestly, they're less likely to die. I mean, that's what, to me, the vaccine is about. It's about death. But that they still have to do the things that promote a healthy body, a healthy immune system, and physically protect them from both getting and spreading the virus. I just don't think we know enough yet, right? And we don't have enough experience, and there's not enough people with immunity where we can say, okay, you get the vaccine, you're done. And I'm really, 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 really emphasizing the need to continue those public health measures. Again, I think this is really powerful because then it takes the weight off the vaccine as a singular method, but puts it in a family of decisions we can make so that the virus has less and less strength in our community. And that, I think, is a literally anti-traumatic and a healing way to approach our community when there is so much historical, racial, and present racial medical trauma.
Thank you. We have a question in the chat. I want Melanie to know I've listed your question. I will come back to you and that question after we have finished a few more presentations. So Dr. Jane O'Halloran, we're turning it over to you.
So thank you so much. I am super excited to get to talk to people about all of this stuff because I hear the questions, I see them being raised in the media, and it's wonderful to have the opportunity to address some of those questions. I do not have all of the answers. I will give you as much of the information as that I have now. The one thing that we've learned about COVID is things change so fast. So by the end of the time I get to the end of this short presentation, there will be a whole lot of more information out there. So I'll do my best to synthesize it as best I can. So I put a few slides together just because sometimes when some of this stuff, it's easier to have a visual. So I'm going to fly through some of those, but please put your questions in the chat. I'm happy to answer them either along the way or at the end. So let me see, can I get this technology to work for me?
Hey,
Okay.
I can't hear you, baby. What'd you say?
Whoever is on, please put yourself on mute while we're live. Thank you.
Okay, so can everybody see the slides?
Yes.
Yeah, great. Okay, so in the interest of my disclosures, I work in a unit that has done some studies on the COVID vaccine. We did some studies on the Janssen vaccine, but there's no financial interest in that. And the other disclosure I have to say is that I do love vaccines. I'm a big vaccine proponent. I love getting vaccines. So that's my own personal stance on the matter. So one of the things that I think it's really helpful to kind of understand is how vaccines are developed, because one of the questions that I get asked a lot in clinic is, well, this seems to have happened so quickly. Does that mean it wasn't done safely? And I think understanding the mechanism behind it certainly helps. So when we're developing vaccines, there's several different stages that or phases that it goes through. There's the preclinical phase, which is the bit in the lab where vaccines are developed using cells or animal models. And then at that point, if things look like they're okay from that stage, which usually takes a couple of months, then it moves into the first in-human studies. And those studies initially are the phase 1 studies that are designed for safety, and they're very small numbers, so usually less than 100 people. Once that data has been analyzed, it then moves on to the next phase, which is kind of an expanded safety and starting to look to see if the vaccines might work at a cellular level or a basic level. And those are the phase 2 studies. And those studies tend to take months to maybe years to complete before we move on to the big studies, which are the efficacy studies or the phase 3 studies. And it's those phase 3 studies that we've been working on over the last 6 to 8 months. And it's the results of those big phase 3 studies that help to inform the different agencies as to if they're going to go ahead and approve these vaccines or not. And once you have done all of those studies, it goes through the approval. And then generally it's at that point where the vaccines go into manufacturing. So you can see that it can be a long process, usually taking closer to years, several years, rather than the duration that we've seen. And one of the ways that time period can be shortened is to combine your phase 1 and phase 2 studies, or to combine your phase 2 and phase 3. And that's a common thing that we do in general in developing treatments and vaccines. But really, why this has happened so fast is probably a lot down to Operation Warp Speed, which was a government and a private and public sector initiative to try and achieve a certain set of goals. And this operation was set up here in the US, but across the world, this has been the priority for scientists and doctors, for governments, for everybody has been really focusing so hard on trying to get a vaccine in place. And when you put the resources of the world behind something, you can certainly speed up how you get to that endpoint. So Operation Warp Speed wanted to be able to produce 300 million doses of vaccine, but in a safe and effective way by the beginning of 2021. And the aim was really to accelerate that development and to streamline it. And the question is, well, how do you go fast? Well, the first thing you do is you don't just have one vaccine that you're walking through the process. You have a number of different vaccines that are in development, so that each of them are at different stages of development. And potentially, if one doesn't work, then you've got another one there that you can continue to develop. You make the studies really, really large so that you can quickly get to the goal that you're trying to achieve, which is to test whether a vaccine, an active vaccine, works better than a placebo or a dummy vaccine. Unfortunately, having lots of infection around, and in this case, having high numbers of COVID in the community, that actually helped to speed up the development, because people who had been involved in the trials were being challenged on a day-to-day basis by the infection. So we could see if the vaccine worked or didn't work. And then money, having the resources, and the resources put in place by governments across the world certainly helped to speed this up, guaranteeing the companies who produce these that they would receive financing to do that rather than take risks themselves. That helped to make this happen faster. And so instead of something taking usually in around 72, 75 months, we got to a point where we had a vaccine within about 14 months. So that's pretty impressive. In fact, we probably had it a little bit earlier than that. The other question I often get asked is, how do vaccines work in general? And in particular, how do COVID vaccines work? So in general, when we get a vaccine, what's happening is we're introducing either a very, very weakened version of a virus or a dead and inactivated version of the disease into the body. Now, it's important at this point to be clear that for the COVID vaccines, all of them are inactivated, dead vaccines. There's no weak virus being injected. They are all totally dead. And once that virus is, or once that inactive virus is in the body, what happens is our immune system sees this and says, hang on a minute, you're not supposed to be here. And it then starts to produce different types of cells and antibodies that prevent the infection, or that would be able to prevent the infection from getting out of control. So it's the same basic principle for all vaccines. A small part of a virus or attenuated virus is introduced to the body. In the case of COVID, that's that little spiky bit, the little red spike that you see in all of the pictures. It's a little bit of that, which is called the spike protein, that's introduced into the body. and then the body recognizes that spike protein's not supposed to be there. It makes the antibodies against the spike protein. And then in the future, if we come across that little protein attached to the COVID virus itself, because we've come in contact with the actual virus, we already have the toolkit there to be able to get going really quickly on locking down that virus so that it doesn't make us sick, or that's the thought behind it. And there are lots and lots of different COVID vaccines, but they all, in the bottom line is they all do the same thing, but get to the same point in different ways. So they all instruct the body to make that spike protein so that the antibodies will then be able to react to it. So there are several different types of COVID vaccines, and this is a question that we very, very frequently get asked. And the different types of vaccines really refer to the mechanism by which they get the body to make that spike protein. So the two common ones that we are using in the US at the moment are the Pfizer and Moderna vaccines, and those are RNA vaccines. And that is a new type of technology, or at least it's the first time we've had a vaccine that's been approved using that technology, but it's been worked on for many, many, many years. And what happens with that vaccine is that a little piece of code, a little essentially message or a recipe or a blueprint is wrapped up in some fat, and that's, or lipid, and that's what makes the vaccine itself. That's injected in, and the cells see it, they open up the envelope and read the message or read the code, and then they do what the code says, and the code says make spike protein, and they make the spike protein, and then the process that we spoke about earlier kicks in. Importantly, because this is something that I hear asked about a lot, that little bit of messenger code cannot in any way affect our genetics. It just can't do it. It doesn't have the ability to do it. It's essentially like the mail person dropping off the mail. They pass on the message, you open the envelope, you read what's inside, and then the mail person leaves. They don't stick around. That's not how it works. The other vaccines do that are available. There's one other one that's licensed in the US at the moment, or is approved in the US at the moment, and that's the Janssen vaccine. And that uses a little bit of a different technology whereby another virus, which has been modified so that it can't hurt us, carries the message to the cells to make the spike protein. And those are the kind of three main types of vaccines, or two main types of vaccines that we are currently using in the US at the moment. But they all get to the same endpoint. And a couple of just important points about the studies, and I'm happy to take any questions on them. The Pfizer vaccine, the Moderna vaccine, and the Janssen vaccine, the ones that are currently in use in the US, those have been studied here in the US and in some other countries in somewhere between 30,000 and 45,000 people for each of those studies. And if you compare that to other vaccine studies, for instance, the hepatitis A vaccine or the hepatitis B vaccine, those studies trialed those vaccines in about 1,000 people. So you can see that these studies have been really, really, really large in comparison to what we normally do. And the last thing I'm going to just say about them on this slide, and it refers really to Melanie's question in the chat, is which one is the best one? And I suppose what I've advised my family is the best one is the one that's available to you, because in the end of the day, they all do one really important thing, which is they prevent severe disease and they prevent death. Those are the really, really important things that we want to happen. You'll see these numbers in the media. Oh, this one is 95% effective. This one is 70% effective. That figure refers to preventing any type of infection. So a mild infection that's similar to a cold will be counted in that setting. But what we're really, really, really looking for is to see that they prevent the severe things. They prevent us needing to be in hospital. They prevent us needing to go to the ICU. They prevent us needing to be on a breathing machine, or worst of all, they prevent us dying. And all of these vaccines that are approved in the US have done that. So from my perspective, the best vaccine is the one that you can get access to. And then the last thing I'll touch on, because it's the thing that I get asked the very most, is what about the side effects? So many vaccines will have some side effects, and these vaccines for sure can have some side effects. The vast majority of these are mild side effects that will last for a couple of days and tend to be things like joint pain, headaches, sometimes nausea, those type of symptoms. And this is actually some good information that I saw from the CDC tracking. So when you get your vaccine, you're given an app that allows you to go on and report any symptoms that you have. And this information here on the screen is from almost 1 million people who received the Pfizer vaccine. So this is way after the studies are done. This is post studies. This is in the general population. And you can see that the side effects vary. Most people will have some pain in their arm where they get an injection, which I don't think is too surprising. We would expect that. And then people will have anything from joint pain, aches and pains, headaches that can last for usually a day or so, but can last for a little bit longer than that. When I got my own vaccine, the first vaccine didn't bother me at all. I thought, oh, this is simple. I'm not having any sort of side effects. I was delighted with myself. The second one was a little bit of a different situation for sure. I had some aches and pains. I definitely felt chilly, and it lasted about 24 hours. But for me, and it was like what Dr. Punch was saying earlier on, you're making the assessment as to what benefit you get. And I was tossing up having some aches and pains and feeling a little bit miserable for, half a day versus protecting the people around me, protecting my family, and protecting the patients that I work with every day. So, for me, it was an easy decision, but I think the most important thing, and Dr. Punch also mentioned this, is that people have the information. Because if you have the information, you can make your decision one way or the other safely.
Okay, thank you, Dr. Halloran. I looked and you answered, I know you answered Ms. Davis, one of Ms. Davis's questions, and many of the questions that we have heard. One last thing I want to ask you before we move to Dr. Maddie, and that is, people have been asking whether these vaccines are effective on the new strains of COVID-19.
Just unmute myself. So that's a really excellent question. And to be honest with you, I don't think we have the full data on that yet. Certainly we are seeing that they are having some effect for sure. They definitely have been shown in some of the studies to, again, prevent that severe disease. But one of the things that has been proposed as to the reason why we see a little bit of different numbers between the Moderna and Pfizer vaccines and then the ones that were tested a little bit later when we had some of the variants starting to circulate, was that perhaps the variants might be impacting a little bit. But again, the thing the take home message is, despite the fact that they may be impacting on you getting an infection, those infections were mild and they were not responsible for deaths. So I have to say, I think the jury is, this is an ongoing evolution, and I think the jury is still out a little bit on their full impact. But to me, I think it is still most certainly worth getting one. That's not something I would sway me against getting a vaccine, because I think they still prevent against the severe thing. It is the question though, is that might be what prompts us to need a booster or a different variety of the vaccine down the line. But we have learned so much in the last, 14, 15 months, and we will continue to do that for sure. And I think, we are in a place where we can certainly prevent severe disease and death through the vaccine. But again, I absolutely agree that and reiterate the importance to continue with all the other things that we are doing too, like our masking and that as well.
Okay, thank you so much. And now we're going to turn it over to Dr. Mati.
So, what more can be said when you've had a powerhouse crew go through so much? And I think for me, I'd like to touch on, in thinking about Dr. Sanders, what have people been talking about? And one of the things that I think is important for us to acknowledge is the disproportionate impact this has had on our community and other communities of color. This signal showed itself early into the pandemic. I can't even believe I'm saying that we are over a year into this, but here we are. And yet for so many in our community, we have had trauma. We have had acute on chronic trauma. Because this is not new. COVID-19 joins a long, long list of conditions in which Black and Brown people are disproportionately affected. We get sick at higher rates and we die. And I'll talk a little bit about why I think that is. But let's look at some numbers because I believe data is justice. The first thing we see here is a table that walks us through the number of cases, hospitalizations, and death. And what these numbers show is comparing the various groups in the columns to the white population. I'm not even going to walk you through this because you don't need to have an infectious diseases degree, right? Or a special math degree to see the trend here. For every single group of color, we have American Indians or Alaska Natives, we have Asians, we have Black or African Americans, and we have the Latinx populations. We have more cases, more hospitalizations, and more deaths. And when you look at our community, the Black community, I'm talking about 1.4 times more likely to get COVID, 3.7 times more likely to be hospitalized, and almost 3 times more likely to die. These figures are unacceptable. And that is even more shocking when you look at the pie chart above me, where we only make up 12.3% of this population. What is really going on here? So yeah, March came, April came, we are again being bombarded by statistics that are traumatic to us, where we again are being disproportionately affected. And then May hits, and yet another Black king is murdered. And we are internalizing that trauma. And then the conversation started. Oh, it's vaccine hesitancy. So let's talk a little bit about that. I don't think we can talk about hesitancy without a little history, because the history of mistrust, the history of valid, appropriate mistrust in government, scientific, and medical communities is as old as slavery. Unfortunately, human experimentation dates back to slavery because the bodies of Black and Brown people were considered property. We had no rights, absolutely none. And so what we saw back then was, for example, Thomas Hamilton, a slave owner and physician at the time, taking Black slaves and putting them in pits, subjecting slaves at the time to high degrees of heat until we either died or passed out in the name of science. And what was that science to achieve? Oh, to make sure we could work longer in the fields. Or maybe we can talk about Marion Sims, considered one of the fathers of obstetrics, who took the bodies of Black and Brown women who were slaves at the time, and without anesthesia, which was widely available, tried to perfect a technique to fix communications or holes that existed between the vaginal tract and the urinary tract. He is quoted as talking about how slaves would cry out in agony, how he thought they would die. It was only then, and let's be clear, he perfected his technique, and only then did he make it available to white women with anesthesia. Let's talk about Henrietta Lacks, a 31-year-old African-American woman who died of cervical cancer. Her cells procured, removed from her body without consent. 20 years later, only then did her family know about this happening, but were provided no accountability, no compensation. And those HeLa cells are cells that people like me and all the physicians out there have benefited from in the name of science. And then there's the Tuskegee experiment. It's funny because I have colleagues who sometimes roll their eyes when I still bring this up, saying this is dated, this surely cannot impact. I work at 2 medical institutions, and I can tell you that multiple times, Black and brown people have cited Tuskegee as the reason why they will not consent to care, the best available care. This was an experiment that ran from 1932 to 1972 to Black men in Macon County, Georgia, who were told that they were going to be part of an experiment that would help them, that would help them with this disease of syphilis that they suffered from. At the time, they were only given placebos. Penicillin became widely known as the treatment that could cure them 10 years later, but up until 1972, it was not offered to not one of them. Just above 50 men died. Close to 100 of their partners were infected and had complications, and 20 children were born with congenital syphilis. Those children, the aunts, the uncles, the relatives, the cousins, live on today. This is a stain, an absolute stain on our community. So I say that to say that this vaccine hesitancy that people speak of is an absolute valid approach. And it makes sense to me that people are not hesitant. I think it's offensive to say that that's what encapsulate what this is. We have very appropriate questions, and we deserve information from trusted resources and trusted messengers. And those may not be the same for all of us, and that's okay. So the chart that I'm showing you here is again showing the point that COVID-19 joins a long list of conditions for which we are disproportionately affected. Look at high blood pressure, look at diabetes, look at stroke, all cause mortality. Death overall from health conditions, Black people once again are disproportionately affected. Last year, I found myself a pregnant infectious disease doctor at the beginning of a pandemic, 7 months pregnant. Stressful enough, not a lot of data on how I could protect my child. And then May came, and it was Black Maternal Fetal Health Week. And I was then bombarded with even more statistics about how Black women die at much higher rates than white women do. I had a white male obstetrician, an absolute gem of a human, who we used to have, they're just the funniest visits. Every month was just sort of check-in casual. But I remember in May, 2 weeks out of having my baby girl, sitting him down with tears in my eyes and telling him how afraid I was and how hard it was to be vulnerable, because I literally felt like the only person who could control some of these poor outcomes that people in my community face was this white man. He listened, he heard me, and he said, I got you. When it was time for me to have my baby and she came early, he was called because he was actually not supposed to be on call. He didn't need to come in, but he told the nurses, I have to come in for her because I promised her. He came only to deliver my baby, and I had a healthy baby girl. That is privilege that I had. So many Black women like me do not have that. So many Black people who suffer from high blood pressure, diabetes, stroke, and now COVID do not have that privilege. So when we talk about vaccine hesitancy, this is a scapegoat, because sure, last year on the left, at the end of last year, polls showed that Black people were least likely to take a vaccine if it became available. If you look at the chart on the left, that's us at the bottom in the yellow, saying we are less likely to. But guess what happened? A movement where trusted messengers brought trusted resources to our community. And the data to the right is the most updated data from 2 weeks ago that shows that Americans who will not choose to be vaccinated if one is available to them, 49% of those are GOP men, 41% Republicans, 40% white non-college educated men, 25% Black. So why is it that I should then show you this chart that says that we across the board, across states, are getting this vaccine at lower rates than other groups? I say to you that for me, this is not about vaccine hesitancy, because no such thing exists. We are appropriately questioning and have a valid mistrust based on an abhorrent history of violence against our bodies. And once given that information in a way that we can comprehend and understand and trust, we make the best decisions for us and our families. And it may not be to take the vaccine like I chose for my family, but these numbers still reflect that there are a lot of people, look at this on the right, a lot of people who want this vaccine, but are still not getting it. So what we should be looking at here and focusing on is access. And I'm proud to say, as a member of the St. Louis Board of Health, that this has been addressed in ways that I have not seen across the country. Unfortunately, vaccine distribution and rollout has been left as a state-by-state decision-making capacity. And furthermore, the rollout was woefully inadequate in December. We did not have enough product. And so local governments and counties were left working with their hands tied behind their back. They had to prioritize high-risk groups, but that didn't mean everybody got vaccine. So I am seeing some questions in the chat where people are saying, you know, I still haven't gotten mine yet, and I meet this criteria, what is going on? And I will say you've been failed, bottom line. And that has to be owned from the top down. However, you do live in a city where the county and the city is dedicated to dealing with data. They went and they studied data in partnership with our local universities to see which zip codes have been disproportionately affected. And a lot of the clinics that you're hearing about are being focused in those areas. You have every right to be frustrated. It is not fair to have to wait. But I come from a country in sub-Saharan Africa where my mother, my sisters, and many of my family members may not see a vaccine for the better part of this year. The United States has more vaccine product than any one country in the world. And President Biden has said that everyone will get a vaccine by May 1st, will be eligible to get one by May 1st. So hold on, guys, it's hard. You have a lot to be frustrated by, but don't let anyone tell you that you don't have a right to ask questions. Don't let anyone tell you that your mistrust is invalid, but instead, do not allow your mistrust for communities that have failed you to get in the way of protecting yourself and those you love. At the end of the day, for me, it came down to this one thing, not the risk and benefit of a vaccine versus nothing. No, the choice I had to make was, what are the risks and benefits of a vaccine versus the risks and benefits of getting COVID, which include death? And that was clear for me. But I am privileged. I have this data and I have this information. So let's use the rest of this session for you to get the data that you need and the information that you need to make the best decision for your family.
Okay, I told you all you would be hearing from really dynamic, powerful people in our community. And I think you have. Thank you, Dr. Madi. Before we get into the general questions, I have one that I need to ask you. That is, who is prioritized for the vaccine and why?
So you heard me touch on this a little bit, but let's get into it. One of the things that we've learned during the course of this pandemic is, again, who is getting this at higher rates than other people? Who is being infected more, but more importantly, who's sicker? Who needs to be in the hospital? Who's likely to get into the ICU and need a ventilator? And unfortunately, who's dying more? And we learned a few things. We learned that it's our older groups. We learned that it's people who have pre-existing conditions like heart disease, like lung disease, like kidney disease. And we learned that it is Black and brown communities that are disproportionately affected. So when it was time to roll out the vaccine, knowing that we didn't have an infinite supply of product, knowing that each state would be given its portion and would really have to responsibly figure out who needed it. A plan was devised that was very greatly suggested that all states adhere to, which was number one, our essential workers, the front line, not just the doctors. I'm so tired of people acting like we're the heroes. You want to know who the heroes are? Our nurses. You want to know who the real heroes are? People who are sweeping our hospitals, cleaning and sanitizing, feeding our patients. These are the heroes. So we prioritized all essential workers. Then we prioritized our elderly and those with pre-existing health conditions. But I gotta shout out Montana and Utah, guys, because I'm a keep it real kind of person if you haven't picked up. They also said, but what about Black and brown communities? And they removed the age gap and gave them as prioritized. I happen to think that's appropriate because the data supports it. You know, but this is why my big mouth gets me in trouble. So when we talk about who's prioritized, that's why this was done. It's because we didn't have an infinite supply of vaccine. You're gonna see in the next couple of weeks that open up significantly. And already hospitals are saying, and Dr. Sanders has posted for you in the chat, so make sure you get those links. Hospitals now, the major hospitals, the city and county health departments, Walmart, CVS, and Walgreens, thank you, Dr. Sanders. You see what happens when you have a friend in charge, child. She'll bail you out. All of them have sign up for you to be able to get on lists. Get on all the lists, child. Let them say no, but don't prevent yourself from your shots. Now, this is another pet peeve of mine. Not all of us have working phones and working internet. So there are community organizations. These are the trusted messengers, led by the likes of Dr. Punch, led by the likes of Affinia and other FQHCs who have earned the trust of the community, that are also making it so that you can get these vaccines. They're coming door to door. They're making sure that when you come to doctor's visits, you're getting this information. So look around, even if it has been hard, please don't give up. We want to get vaccine to you as soon as possible.
I have to thank you for that. That really speaks to the question that Ms. Davis asked, because she pointed out she is 65 years of age and she's gotten on lists and she still hasn't been called. I know we put in the chat the state of Missouri, the St. Louis County, St. Louis City lines, and I think we did not do what you did, and that is recommend Walgreens, CVS, Walmart. They are options. I have had people suggest to me that they are having an easier time going through those three. Well, what I will say is some hesitance has been around Walmart because they're asking for insurance information. But if you've got to give that up to get vaccinated and that's what you want, I would try the others, but that may be what you have to do. But don't give up if it's what you really want. There are also a couple of churches that are helping people, and I will try to find a couple, at least one of those to put in the chat before we get off. But now we're going to open it up to general questions to all of our panelists. And to start out, I have one. Will the vaccine interact with any of the medications a person is on? Do they need to be concerned if they're on medications?
Way to go first. So no. So the vaccines will not interact with any medications, but it's a really good question, because one of the things that we're learning about and we're working on is, will the vaccine work as well for everybody? And there are some people who are on medications that impact their immune system, and you know, those medications will not cause more side effects. They will not cause more harm, but the vaccine effect might be a little bit less. We don't know that yet, We are doing that work to try and figure that out because it's a really important question for people who have certain medical conditions. But we are not there so far. There has been no evidence that there's anything that you take, any medications that would make your side effects any worse.
Okay. We have another question in the chat from Lori Jones. So we want to open up schools, but we didn't prioritize teachers for vaccines. We have essential workers in retail, i.e. Walmart, who have hundreds of exposures, but are not prioritized for vaccines. What are your thoughts on this? This is open to all of you.
I think they absolutely should be, but it's a balance, right? We have so much vaccine product. So this is where I will not bash local and local governments, the county or the city. You know, each state gets vaccine and each state allocates that as it sees fit. I'll tell you, there were times sitting on the board where I couldn't understand why certain jurisdictions went a week with minimal product, if any at all, while others weren't. It wasn't as transparent of a process here. And I think it was frustrating for people to see what was happening in other states. I've personally called for a more standardized approach to this from the federal government. Dr. Nunes Smith, who has been tasked with equity around vaccine distribution, did a phenomenal talk today. We'll be doing another one on Friday. The CDC has released funds for that, for projects within the community, for research to be continued. And I do believe with more product, you will see that continue to happen. You know, the conversation in schools was hard for me to watch because as a parent, I get it. You know, our kids are our future and we should be centering them. But I could understand how painful it was for teachers to not hear enough of how important their lives were too. It's the same with single people. You know, you kept hearing about mothers and fathers, but there were people who had to shelter in place for months and months and months without any human contact and touch. And you just didn't see it centered. There's a Hunger Games type attitude that unfortunately has been enforced upon us that is so unfair and it is so unjust because it makes it seem like one person should and another person shouldn't, when in fact, there are many, that term essential should be much broader than it is. And I would include in that people on dialysis, for example. But I will say, as someone who has seen some of the issues around allocation, the product just wasn't there. And some of that is down to our state officials and now our federal government. We have more vaccine product than anywhere in the world. I stay up at night thinking about my mom and my sisters. We have the ability to get people vaccinated in this country. And so over the next couple of months, the accountability has to be, are we going to do a better job of making sure that people that need this are going to get it? And I'm a hopeful person, so I believe that will happen.
Thank you. And I know Ms. Hooper has information from St. Louis County that she's going to share on the issue of the schools and county efforts.
Yes, so I just wanted to add that just recently the county wanted us to let know that schools are hosting vaccination events, and the County Department of Public Health is beginning to vaccinate education staff as well. I know during the registration, someone also had asked about if school districts will let the public know what percentage of their staff is vaccinated. And so from speaking from a county standpoint, that will be up to the school districts. St. Louis County Department of Public Health will not be providing that information.
Is there an event? I want to say there may be an event on the 24th for schools and teachers. And I'll try to find that as well. Okay, so I'm going to switch us to another question. Someone asked, can I still get COVID-19 after my vaccine?
Yes.
So if you can still get COVID-19, then what's the benefit of the vaccine?
So what we've seen so far is that, yes, there are vaccines, that 95 number or that 75 number, those 5% or those 25%, those are people who still could potentially get COVID after the vaccine. But what we've seen is it's been mild, and it hasn't been severe or life-threatening in the vast majority of cases in comparison to the other group of people who didn't get vaccine. And that's why at the moment we are still encouraging people to continue wearing their masks and to do their distancing and their hand hygiene, because if you have the vaccine but your family members haven't had the opportunity to get it yet, or your friends or people you're working with or people you're mingling with haven't had the opportunity to get it, you could have it but have a mild version, and you don't want to transmit that. The idea is that we want to wait until we get as many people vaccinated as possible to try and protect as many people. But what we have seen is that people who do get it after being vaccinated tend to get mild infection. At least that's what we're seeing at the moment.
Another question.
I just want to nuance that a little bit though,
Okay.
because for me, I worry, especially for people for whom they're walking into the vaccine decision with the particular burden that we've already mentioned, right? If that person, right, gets the vaccine and then ends up not only getting the infection, but somehow giving a vulnerable family member the infection, I really worry how damaging an event like that is. And so I've really been emphasizing that the vaccine is about making it so you don't die.
Yeah.
But there's so much more to learn. And it's really important, I think, to emphasize that we are in an unknown, just like we've all said, and it's a point in time of information. But if we give people the vaccine is about severe disease. It's not about the infection. Infection is a mechanical reality. Disease is your immune response, right? And so I think it's really important because we will create so much harm if even one person, right, is sold the idea that if they get the vaccine, they won't get the infection. And then they're the reason, not even that they get sick, but that somebody they love gets sick. That will crush our community in a way that's just not going to be easy to fix. So I'm super cautious in telling people this is about you not dying. And when we learn more, then we'll know more. And hopefully we can say more and hopefully it'll get better. But for now, that's all we can say.
But I think that's the reason I like the fact that you and the Prepare STL team and the materials that you have sent out and yes, I have them, and we've been sharing them, that we continue to mask and we will continue with physical distancing, that vaccination does not mean that as a community, we need to cease with all of the precautions that we have learned to take. So I want to thank you for emphasizing that at the beginning and now in the middle. And if someone can remember to emphasize this again at the end. We have another question in the chat. What effect does the number of people refusing to take the vaccine have on achieving what is called herd immunity? Will herd immunity be delayed or not attainable?
So, this herd immunity and reaching it requires 70 to 80% of the community taking the vaccine. A lot of people ask me, when will we get back to normal? And I say, never. We will reach a new normal. We've changed. Our culture has changed. Last year, by the end of the flu season, I beg your pardon, 200 children in the United States had died. As of February of this year, 1 child had died. And we hadn't changed, we were giving the same amount of flu vaccines, but what was the big thing that we changed? We were social distancing, we were masking, we were using hand hygiene. We have changed, we have learned so much. We have never experienced collective trauma the way that we have in this pandemic. So we're going towards a new normal. Ideally, we would like to reach herd immunity, because then even the few people that choose not to take the vaccine would still gain protection from the overall group that have been vaccinated. That would be the safest way for us to open up our businesses, our socializing events, and try to have this new normal. If we do not, we will continue to have this sort of stepwise patchwork effect. You see what's happening in Miami during spring break right now. And it's times like these, especially around holidays, where we see these spikes and we continue to lag behind. This is not new. There's countries that have done this, right? There are countries who said, we're going to do this. We're going to shut it down. It's going to suck. And it did. We saw videotapes from freaking Italy where people were in their little apartments singing and playing musical instruments together. And we were all like, but you think they were having a cute time? I'm sure they were ready to pull their hair out, right? But they did it. They locked it down. They shut it down. And they were able to open up safely for an extended period of time. The same is true here, guys. There are things that just need to happen for us to get there. And if they don't, we just need to accept that our new normal will look different and will make it difficult to achieve the community goals we have, and will make it difficult to protect ourselves and our loved ones. That's basically what this comes down to. But, you know, my other panelists may have a much more eloquent way of putting it.
Other comments?
No, I think Dr. Hlathswayo got it. So I think we are looking at potentially a new normal for some time, for sure. And you know that we've learned, we're adjusting. We're not necessarily happy about it, but you know we will get there.
I have someone has asked in the chat, will there be walk-up vaccine opportunities? So people can just come when they're available if the vaccine is being distributed and receive it. Is that likely to happen? Does anyone know?
Unfortunately, because of the vaccine product, that is not being done in an organized way. I want to shout out Craig Schmidt, who has joined us tonight and who is a champion within our community, who puts it beautifully. He says, currently we are abiding by state tiers with appointments only. We need to know that there is the proper amount of vaccine available by appointment. If there was an unlimited supply of vaccine, walk-ins would be a great idea. That's just not our reality right now. The caveat is, you know, as someone who vaccinates for the community, we tell people, because some people will show up and we tell them, we cannot assure you, because they know that there may be leftover vaccine product at the end of the day. So they say, if I come back, can I get vaccinated? And we tell people, we cannot assure you of that. And we do not want you getting upset or having us commit to a time that you can do that. I personally don't think that is, I'm a highly anxious person. That would have given me great anxiety to pop up, be like, should I come back? What time? Come back. And then there isn't vaccine. But, you know, if that's your jam, you know, maybe that's how you want to spend your Saturday or Sunday. But like Craig said, that is just not the way we're able to do this. We're still having to prioritize high risk groups. And that has been by appointment only. But I do believe that is going to open up more so as we're seeing more vaccine being shipped out to states the way it has in the last couple of weeks.
And then we have the question, if one of you can speak to whether, clear up the reports that the vaccine has helped to clear up or reduce some of the post-COVID lingering effects for people who already had COVID, and the recommendation that if you had COVID, you still get the vaccine anyway.
So I don't think, being honest, I don't think we have evidence to say that the vaccine clears up any lingering symptoms that people would have. And some people do have symptoms that linger for a long time. And that's the other thing that, you know, we often we talk about severe disease, but what's actually impacting somebody's life may be something different. It may be some of these lingering effects that don't necessarily reach the level of severe, but can cause them to feel pretty unwell and impact their life for some time. Should you get vaccinated if you have COVID? Yes. the answer to that is yes. The CDC recommend, and a lot of other agencies recommend that you do go ahead and get that. What we're learning about is the difference between the immunity that the vaccine provides us and the immunity that natural infection provides us. At the moment, it looks like getting the vaccine helps to boost that if you've had it some time ago. And often people ask, well, when should I get it? And the recommendation is once you've recovered and you're feeling better from those symptoms, then you can go ahead and get it. There isn't a particular time frame. There isn't a too soon or too late. It's just when you're feeling better and you've recovered and you're feeling back to yourself.
The next question we have is booster shots, and why would booster shots be necessary?
So that's a little bit in the unknown category again. What we know so far is that for several of the vaccines, the Moderna vaccine and the Pfizer vaccines, we give 2 vaccines. For the Pfizer vaccine, it's 1 month, 3 weeks apart. For the Moderna vaccine, it's 1 month apart. In a way, those are kind of like booster vaccines, but I think what we're talking about here is, will we need a booster vaccine in a year or in 2 years or in 5 years? And we don't have that information yet. What I will say is that the studies that were designed were set up to look at the immediate impact or the immediate effect of the vaccine, but all those people in those studies are being followed for up to 2 years to try and get that information that people want to know about whether we need that booster or not. Will this be like a flu vaccine where we need it every year? Will it be like a pneumonia vaccine where you get a shot in 5 years' time? We don't have the full answer to that yet, but that is something that people are trying to get people an answer to.
And this may be the last or next to the last question. For individuals that have transportation and work schedule challenges, has providing transportation and flexible hours for those whose schedules don't allow them to get the vaccine been considered? I mean, the scheduling is really for people who have some flexibility in their lives, and everyone isn't able to just be there when they say, you've got to arrange this with your boss, your supervisor. What do people think? Is there any flexibility? Will there be any flexibility?
So one of the reasons why I recommend people signing up for different lists is because that does give you some variability. Most of the vaccine events they've tried to do on the weekend to try and accommodate those schedules, but obviously the hospitals will also have a little bit more varied because they can have vaccinators at different times during the week and on the weekend. So I would say sign up for different types of lists if you can. I will say, and I'll ask Dr. Sanders if she has information from the county, that the city health department has been working on mobile units to get to people who cannot leave their homes or are incapacitated or for whom transport is an issue. I am working with the Clergy Advisory Board to mobilize church vans that have been otherwise used for Sunday service to help with transport for most impacted zip codes. And so a lot of people are thinking about this. I just don't think we have, we are where we need to be. So I really appreciate that question, because I think as a community, we need to be holding each other accountable and giving each other these ideas so that we can bridge some of these gaps. But does anyone else want to speak on behalf of some of the things the county is doing? Because the county's been doing phenomenal work.
I do know that the county is doing some mobile work. They have particularly focused on individuals who are in congregate living facilities, unable to easily get to vaccination sites. But they are thinking about these mobile options, and they have implemented, at least in that group, and I expect to hear that they've implemented beyond those groups.
If I could, Dr. Thompson, this is Damon Broadus with St. Louis County Department of Public Health.
Thank you, Damon, for jumping in.
No problem. We do have a homebound program where we just launched it recently with our fire and EMS. And it's a mobile vaccine program that will visit homes for the homebound. We established a screening process for each person who wishes to qualify for the program. We follow CMS's criteria, Center for Medicare and Medicaid Services criteria for screening patients. EMS will go into the home. They will vaccinate the caregivers as well as anyone over the age of 18 who live in that same home that is tier eligible. The only vaccine being administered for this program is Johnson & Johnson's. And if you know of anyone that might be homebound or interested, you can have them call us at 314-615-2660. And we have navigators that conduct the initial screening. And then we have nursing students from SLU and UMSL who are partnering with us to conduct the screening into that homebound program.
Thank you. Can you drop that number in the chat for us as well?
Yes, I can. And I was trying to drop the registration information for the county in the box. I shared it with Ebony and Paula so that they could put it in the box. For some reason, I couldn't do that.
Okay, great. You know, this has been a wonderful conversation. I really appreciate having Dr. Mati, Dr. Punch, Dr. Halloran here, sharing this information, answering questions. People have asked the questions that I have been hearing in the community. I just want to say thank you. Thank you for your questions. Thank you for the answers. Thank you for being as open and honest. You all have kept it real. You have not tried to just, bring people along without them having open, transparent, accurate information to make the decision. And that's what we wanted. I am going to turn it over now to Ebony Hooper to close us out.
Thank you. Again, I want to echo everything that Dr. Sanders Thompson just said. This has been an amazing evening. And then I also want to take some time to just acknowledge again our great panelists, our moderator, who is also a part of the ReCAST advisory board. Also this evening, I see several of our community delegates and community guiding board members are here. I also want to really thank the PRAB and others from our core advisory board that has joined us this evening. Craig, Carlette, I don't want to get to naming names because then I'm going to skip somebody and I don't want to do that. And so, but I do want to acknowledge that I see you all, those joining us from the county, I see you all, and I really thank you for your time this evening. And just to wrap things up, again, ReCAST is all about participatory budgeting and creating platforms to empower residents to really have a say in the governance of the well-being of their communities. And so tonight's event goes to show the great ideas and questions and thoughts and input that our community residents have and are able to bring forth and make events like this happen because we created a platform for their voices to be heard. And so I do want to invite everyone in the chat box. We are having a coalition meeting, a coalition stakeholders meeting on Monday, where you can come, whether you're a resident or representing an organization, to learn about ReCAST efforts and the many grants and contractors that have been awarded through our process, and learn about the projects that have been awarded this year and the work that they are doing thus far. And also, next up, as I mentioned earlier on the call, we have a webinar series going on. And next month, we are going to be focused all on our residents with an April series about amplifying your voice and furthering participatory budgeting and how you can really activate, whether it's engaging with elected officials or working with faith leaders around corralling your community to really be change agents where you live. And so there's a link to register for both of these events. And lastly, before you go, Ms. Paula, if you could drop it in the chat box again, we do have an evaluation and feedback form. We would love your input about tonight, and whether you're here in the Zoom room, watching us live on Facebook, or catching the replay. Thank you for being with us. Have a great evening.
Thank you all.